My name is Srđan Verstovšek. I'm professor of medicine in the Department of Leukemia at the University of Texas and the Anderson Cancer Center in Houston, Texas. Thank you very much for joining us today for discussion on a hot topic of JAK inhibitors for the successful management of patients with Polycythemia Vera. This is an interactive patient case challenge. Our case is based on a 71-year-old gentleman who was diagnosed with PV about 3 years ago based on the cardinal findings in these patients with elevated red blood cells, platelets, low erythropoietin, and a JAK2 V617F mutation in the setting of unprovoked deep vein thrombosis. As is standard practice, he was managed successfully for several years with the low-dose aspirin, phlebotomy with the goal hematocrit of 45%, and hydroxyurea because of his age, and that was 500 milligrams twice daily. However, now he presents with a non-healing leg ulcer and symptoms. He occasionally still requires phlebotomy. We did the workup, and his complete blood cell count revealed uncontrolled red blood cells, platelets, and white cells. On peripheral smear, we did not find a blast or nucleated red blood cells. His ferritin level was decreased, as was erythropoietin. Chemistries in general were within normal limits. On physical exam, the spleen was palpable but only to 3 centimeters below left costal margin, and a bone marrow biopsy that was done showed only 1 out of 3 grade fibrosis and normal cytogenetics. A question related to this case is the following. Which of the following treatment options would you recommend for this patient at this time? Interferon, hydroxyurea continuation, busulfan, pipobroman or radioactive phosphorus, or number 5, Ruxolitinib. So at follow-up after the workup, the patient was found to be intolerant to hydroxyurea. Therefore, Ruxolitinib 10 milligrams twice a day was prescribed, and 6 weeks later, patient was much better. He had marked improvement in quality of life, the spleen was not palpable anymore, and the leg ulcer was healing. His blood cell count was now within normal range. Recommendations for first-line therapy in Polycythemia Vera by experts in the field is listed on this slide. Everybody should have a low-dose aspirin given unless it's contraindicated, and we should manage cardiovascular risk factors that can contribute to increased risk of thrombosis. The first-line therapies are usually assessed based on a risk for thrombosis, not for a risk of progression or dying from the disease, which is in general relatively benign. So patients that are low risk, they would require only phlebotomies. The high-risk patients that are defined by age over 60 or previous history of thrombosis would require, on top of phlebotomy and low-dose aspirin, cytoreductive therapy, and the first choice usually is hydroxyurea, although alternative interferon is listed as well. There are other indications for introduction of cytoreductive therapy, which would include poor tolerance to phlebotomy, symptomatic progressive splenomegaly, and importantly, severe disease-related symptoms, very high platelets, and progressive leukocytosis. Now here I'd like to pay attention to platelet number. The platelet count is not a risk factor for thrombosis. The indication to treat patients for high platelet count only comes into the play when the platelets are so high, like it's indicated here, of a 1.5 million or higher, when there is associated acquired von Willebrand factor deficiency present, which would put the patient at the risk of bleeding, not at the risk of thrombosis. That is an important factor for managed patients in everyday practice. For elderly patients with a shorter life expectancy, busulfan is still an option. Now, we always aim to control hematocrit with cytoreductive therapy, phlebotomy, but European LeukemiaNet definitions for overall successful therapy in PV have been devised to reach beyond just control of the red blood cells. It's presented on this slide. This would include also control of the platelets, white cells, spleen, and symptoms. So in clinical studies, for example, we look at these 5 factors to assess the efficacy of any therapy. There is therefore complete response versus partial response and no response as outlined here. The hematocrit goal of 45% or less at the target for phlebotomy and or cytoreductive therapy has been recently validated. And I direct everybody to perhaps read a paper by Dr. Marchioli and colleagues in New England Journal of Medicine in January of 2013, where they showed, as is shown on this graph, that the risk of cardiovascular-related death or major thrombosis is increased fourfold in patients with hematocrit above 45%. This was a randomized prospective study in high-risk polycythemia vera patients with a target control of hematocrit below 45 or between 45 and 50. And here we see how important it is to control hematocrit below 45%. Furthermore, another important finding from the same study is that the risk of cardiovascular events in general is increased approximately threefold in patients with hematocrit above 45. Therefore, it should be standard practice to aim for tight control of hematocrit below 45% in our management of patients in everyday practice. Let's talk a little bit about the symptoms in PV. As was mentioned before, uncontrolled symptoms are one of the indications for introduction of cytoreductive therapy in otherwise low-risk patients. Although that is relatively unknown, these patients can suffer, as is seen on this slide, with significant symptomatology. Across the board, these symptoms are similar to patients with ET and myelofibrosis. Therefore, it will be prudent in management of patients with PV to either introduce a regular questionnaire that would assess properly in semi-objective way the symptomatology of the patients and how their quality of life is with or without cytoreductive therapy. Now, the progressive leukocytosis is another indication for introduction of cytoreductive therapy. On the other hand, there are several retrospective analyses, and two of them are shown on this slide, that suggest that the actual leukocyte number might be prognostic for these patients. As shown here, the risk of death and the risk of transformation in the analysis done by Dr. Alvarez in Spain, as well as risk of thrombosis in a study by Dr. Landolfi. In all these studies that I mentioned so far, the analysis was retrospective, and therefore the introduction of the leukocyte count as a prognostic factor for everyday management of patients of PV is not in place yet. We need prospective randomized studies to validate the significance of a leukocyte count for prognosis of these patients. So as we engage in a therapy of high-risk patients with hydroxyurea as a frontline therapy, we may encounter problems. And the experts in the field came together to perhaps define what a resistance or intolerance to hydroxyurea in PV patients might be. The common findings and the opinions are summarized in this slide, and we have here 5 factors that ranges from continuous need for phlebotomy, uncontrolled myeloproliferation, both of these with a good dose of hydroxyurea in place. And then we have a persistent splenomegaly, cytopenias, or other non-hematological toxicity. When we talk about the frequency of resistance or intolerance to hydroxyurea, using these factors, these 5 factors, we can only apply this retrospectively in nature, and that was done in Spain in 261 patients, as outlined on this slide, where we came up with the findings that about 10% of the patients over time may develop resistance, and time to resistance is usually about 5 to 6 years, and about the same number of patients may have intolerance to hydroxyurea, which usually happens after about 3 to 4 years. What are the non-hematological side effects of hydroxyurea? A very large study done across Europe in almost 3,500 patients with myeloproliferative neoplasms revealed that the intolerance to hydroxyurea does happen in 5 to 10% of the patients, and those are usually, in great majority, confined to mucosal or cutaneous lesions as the picture of one of my patients reveals on this slide. This is the leg ulcer, typical leg ulcer that happens with hydroxyurea use over time in some patients. Other side effects, fever, pneumonitis, are very rare. What is the effect of hydroxyurea resistance on survival or disease progression in polycythemia vera was again addressed by very nice work by our colleagues in Spain. Using these definitions, they were able to retrospectively analyze the outcome of the patients that were resistant or intolerant and found that resistance to hydroxyurea implies, perhaps not surprising, a significant, and in this case 5.6-fold increase in the risk of death and 6.8-fold increase in the risk of transformation. Perhaps that's not so surprising because if the patients are resistant to hydroxyurea, that perhaps underlines different, more aggressive biology of the disease. This is being studied. But for the implications in everyday practice, this is significant because these patients, again, are at increased risk of transformation and risk of death. On the other hand, intolerance to hydroxyurea had no prognostic significance. So what are now recommendations for a second-line therapy in polycythemia vera if we have a patient, like our case, where the hydroxyurea does not work or a patient is intolerant to it with, for example, a leg ulcer? According to the guidelines, we may use interferon, or if the patient was given interferon as a front line, then we would use the hydroxyurea second line. Other options are not very good ones. Busulfan is usually because of known association with acute myeloid leukemia transformation on this drug, only reserved for patients with short life expectancy. Pipobroman or radioactive phosphorus are extremely rarely used because of known, again, association with transformation to acute myeloid leukemia. Therefore, we come now to a new medication that was approved for polycythemia vera, and specifically in patients with inadequate response or intolerance to hydroxyurea in the United States, or in patients resistant to or intolerant to hydroxyurea in the European Union. And we, of course, are talking about Ruxolitinib, a JAK inhibitor. Now, why would we use a JAK inhibitor in PV? The underlying biological abnormality in polycythemia vera and in other myeloproliferative neoplasm is abnormal myeloproliferation because of hyperactive, uncontrolled, or dysregulated JAK-STAT signaling pathway inside the bone marrow cells. The JAK2, in particular, one member of the 4 family members of the JAK families, is associated with erythropoietin, a growth factor for red blood cells. The erythropoietin receptors, as outlined on this cartoon, is associated with the JAK2 enzyme. The same happens with thrombopoietin and thrombopoietin receptors, which is a growth factor for platelets. Both of these growth factors signal in the bone marrow cells through JAK-STAT pathway for cell growth. With the mutation in the JAK2 gene, and most common is the JAK2 V617F mutation, we have uncontrolled growth of the bone marrow cells. So dysregulated JAK-STAT pathway is the problem, and one does not need growth factors anymore. The cells grow without control. Therefore, the use of JAK inhibitors to inhibit JAK-STAT pathway may benefit the patients, and we will see in the next few minutes that this is actually true. So here we have a design of a study that was done with Ruxolitinib in polycythemia vera patients, so-called response study. This was a randomized study where it was best available therapy in patients that were resistant to or intolerant to hydroxyurea, according to criteria that I have described before. In these patients, there was a need for introduction of therapy because of a requirement for phlebotomy, and they also had a big spleen. As it's seen on that slide, the randomization took place over about 32 weeks, but the crossover was allowed for progressive disease or after week 32 if there was no satisfactory response to BAT. Now we have a chance to look at a longer-term follow-up of this study at week 80, which was a pre-planned analysis. At this time, we were looking at several aspects of the benefit. The benefit was assessed in this study by primary endpoint combining hematocrit control, which would be less than 45% all the time, as well as more than 35% reduction in spleen volume as measured by MRI. This would be analysis at week 32 as primary endpoint. Of course, we would look at other benefits, as was mentioned before. We want to know whether the symptoms are better and whether we control the white cells and platelets in addition to red blood cells and spleen. Based on patient characteristics are shown on this slide, and the randomization, very well randomized patients in their characteristics on both arms without any major differences. Importantly, the BAT, or Best Available Therapy arm, included several different options for doctors to choose from, and as it's shown at the bottom of the slide, in about 60% of the patients, that was actually hydroxyurea, reflecting a need for something new because there were no other viable options. In some patients, interferon, anabolide, or other medications as listed on the slide. At week 80, the disposition of the patients is now shown on the next slide. Most of the patients, almost all of the patients, crossed over to best available therapy after 32 weeks, and by week 80, all of them did. And therefore, we have less of a knowledge of a long-term ability of a best available therapy to control the symptoms, but clearly the analysis at 32 weeks, which led to approval of ruxolitinib, showed superiority of the ruxolitinib over best available therapy arm. The dose that we use of ruxolitinib in Polycythemia Vera, before we go to analysis of results, and because this is very important for everyday practice, the starting dose of ruxolitinib in Polycythemia Vera, unlike in myelofibrosis, for which this medication is also approved, is 10 milligrams twice a day. So everybody should be started on 10 milligrams twice a day as a starting dose. And about a third of the patients will stay on that dose, as it's shown here in the yellow colors. And majority may need adjustment to a higher dose, which is fine. We start with low and increase slowly to high dose if necessary. Only about the 10% of the patients will need less than 10 milligrams twice a day. Now, to go on with the results, on the next slide we see the actual result of the study. Primary endpoint and individual components of primary endpoints are outlined here. Individual components of primary endpoints were reduction in spleen volume and hematocrit control, markedly superior for ruxolitinib, and therefore the primary composite endpoint is, as shown here, markedly superior and led to approval of the medication for second-line therapy after hydroxyurea in the United States and European Union. Durability of primary response with ruxolitinib is remarkable. Patients that respond basically stay as responders for a very long period of time. Furthermore, durability of hematocrit control, if you just focus on the red blood cell control, is also remarkable, and long-term evidence is shown on this slide. The alternative way of looking at the response is to check how many episodes of phlebotomy a patient needs, because after all, the physicians in individual cases would decide when the phlebotomy is needed, not only based on the blood cell count. And it is remarkable to see comparison between the groups of the patients, as is shown on this slide, how ruxolitinib markedly decreases the need for phlebotomy, which is something that is perhaps more applicable to everyday practice to understand the real utility of the ruxolitinib in controlling the hematocrit by elimination of a need for phlebotomy over time. What happens with the spleen is shown on this graph, and as expected from past experience with ruxolitinib in myelofibrosis, it is very effective on a big spleen, and in fact the spleen volume decreases over time the longer we treat the patient. Overall improvements in the blood cell count also improve steadily over time. We are here talking about combination of controlling the red blood cells, platelets, and white cells, which is complete hematological response, which is seen in majority of the patients over time, and it gets better as we treat patients longer. Improvement in the symptoms has a very significant impact on the patients because these patients are not just at a high risk of thrombosis, their quality of life is usually poor, as seen on the slide, and the slide actually analyzes each individual symptoms separately, which is quite impressive here to see that, for example, tiredness or itching or night sweating improves significantly in majority of the patients, and these benefits are usually seen within a month, right away with ruxolitinib. The next question was, what happens with patients that are officially not found to be responders? So not complete control of hematocrit all the time during the first 32 weeks, and no significant reduction in the spleen. This is very important and analyzed in detail because no therapy that we know usually is judged just by having response or not having response. What happens with these non-responders was presented recently, and we found, as is shown on this slide, that the time to subsequent phlebotomy in patients that were officially non-responders, in fact, has been markedly delayed versus patients that were treated with best available therapy arm. So much so that the median time to next phlebotomy in non-responders to ruxolitinib was 1 year, markedly better than the patients on best available therapy arm. Similarly, in terms of the symptomatic control, patients that were officially non-responders by very strict regulations of the study had marked improvement in the symptoms, similar to the official responders. So there is a grade here between really not having any response and having a response that satisfies the strict rules of the study. Majority of the patients that are in between, in fact, have a clinically relevant benefit. Finally, if you ask the patients how they feel, this is so-called patient global impression of change, patients just say whether they feel any better, very much or much improved, or minimally improved, or worse, much worse, and so on. You would see, as it's shown on this slide, that the patients, even though they may not have a complete control of the counts, feel much better. What about non-hematological adverse events? Here, a rather complicated table is presented to include everything that has been recorded, but the overall summary is that we do not have major toxicities identified in the study. The patients enjoyed the efficacy of the therapy without major toxicity. There is one aspect of the adverse events that needs to be emphasized, however, as is shown on this slide. This is a herpes zoster infection, which is very well known from experience in myelofibrosis already. Ruxolitinib does have a potential to alter to some extent immune system, and patients may be at somewhat increased risk of atypical infection. And herpes zoster has been noted to be more common in patients on ruxolitinib than on best available therapy arm in this particular study, just confirming prior observation. Another aspect of the safety analysis of ruxolitinib in PV is that, as was seen before in patients treated for myelofibrosis, is that we are here controlling of a good control of signs and symptoms of the disease, but the progression to myelofibrosis or acute myeloid leukemia still stays with the patients for the rest of their life. We are not eliminating disease or eliminating risk of progression. We are controlling the signs and symptoms of the disease, in this case, polycythemia vera after hydroxyurea, to a great extent for many patients. Finally, from the safety analysis, thromboembolic adverse events were recorded, and, perhaps not surprising, with the good control of signs and symptoms, there is a suggestion that the thromboembolic events, or their rate, is significantly reduced with ruxolitinib versus best available therapy arm. Why would that be? One explanation is not just the good control of a proliferation, because its anti-proliferative medication decreases the blood cell count to normal levels in majority of the patients. It is also anti-inflammatory medication. The inhibition of the JAK pathway decreases the inflammation that comes with the myeloproliferative neoplasms. And as shown here, ruxolitinib improves CRP levels in PV in a separate study but may explain to extent why would there be decrease in a thromboembolic event in these patients. Finally, to conclude, we say that hydroxyurea is largely considered frontline cytoreductive therapy in high-risk PV patients, which we need to understand what the high-risk PV patient is, as we have analyzed. But there is a group of patients that are resistant or intolerant to hydroxyurea, which is about 20% of overall PV patients. In these patients, the resistance includes a group of patients that have a poor prognosis. The resistance, in fact, increases the risk of transformation and early death. In this group of patients, Ruxolitinib is approved. It is approved for, in the United States, patients with PV who have inadequate response or are intolerant to hydroxyurea. And importantly, the starting dose is 10 milligrams twice a day for all the patients. It does reduce hematocrit, eliminates needs for phlebotomy, reduces the spleen, controls the platelets, white cells, and the symptoms. And these benefits of Ruxolitinib are durable. Therefore, to conclude with possible algorithm for PV treatment in 2016, I presented this last slide where we would certainly, in newly diagnosed Polycythemia Vera patients, assess the risks, but also symptoms of the patients and properly provide aspirin and phlebotomy, and then decide on cytoreductive therapy based on those risks and symptoms, with cytoreduction with hydroxyurea or interferon preferred for frontline use. But then if there is a worsening of the symptoms, vascular event or progression or resistance or intolerance to those, the second-line therapy should be Ruxolitinib, or in those patients that previously were not treated with interferon can be considered as well. With that, I would conclude the presentation. I thank you very much for joining us today for a lovely discussion and analysis of the topic of JAK inhibitors for the successful management of patients with Polycythemia Vera, which we based upon the patient case. Thank you and have a nice day.